Kia ora koutou, and welcome to tonight's Goodfellow Unit webinar on high-risk cutaneous squamous cell carcinoma, supported by Olivia. My name is Dr. Courtney White, and tonight we will hear from Mr. Rajan Patel. As a head and neck surgeon since 2005, Rajan has extensive experience across multiple facets of the field. He was awarded an MD for his research efforts in 2005 and then completed fellowship training in Toronto and Sydney. Rajan has held roles at Auckland Hospital, Auckland Head and Neck Surgery, and Olivia Head and Neck Surgery, as well as being the New Zealand Convener for World Head and Neck Cancer Day. Rajan has published over 40 articles and written several book chapters. I will now hand over to Rajan. Thank you.
Thank you, Courtney, and to Goodfellow for inviting me to speak on this subject, high-risk cutaneous squamous cell carcinoma, which is clearly a very relevant subject in New Zealand. So look, I'm just going to go through a slideshow really defining what I mean by high-risk cutaneous squamous cell carcinoma, why it's important to recognize these cases, and then we can talk about how to manage them or what you should do, what you should be looking out for. So, as I said, the goal of today's presentation is to identify what a high-risk cutaneous SCC case is, and then to provide a sort of framework of how to manage these patients with the aim of improving survival and reducing morbidity for these patients. So as I mentioned, cutaneous squamous cell carcinoma is common, as I'm sure many of you are aware. And in addition to this, the incidence is increasing. Thankfully, most of these cutaneous squamous cell cancers are considered low risk and are cured by simple excision. But there's a minority of cases that are high risk. And the challenge for you and for me is to identify, differentiate which of these cases is high risk. When we talk about high risk, we're concerned about the risk of either recurrence locally or metastasis and even death. So these cases present a significant potential for these morbid and mortal issues. The definition of high-risk cutaneous squamous cell cancer is a squamous cell cancer that is considered to have a greater than 5% risk of local recurrence or metastasis. And by recognizing these cases, we can then start to consider what additional or different treatments we should be offering these patients, and indeed what follow-up is required. So in summary, not all squamous cell cancers are considered or treated equal. As I mentioned, there's a small subgroup of high-risk cases. So how do you recognize these cases? There's 3 slides here that I've broken down into history, clinical findings, and then pathology findings. So when we're talking to our patients, the history, we need to consider, have they had previous history of cutaneous squamous cell cancers? Is the cancer or the lesion that we're looking at, is it in a site that's been previously treated? Is there an obvious scar, or do you know this patient has had surgery in this location? And then in their past medical history, we need to understand whether they have any of these chronic diseases that poses a significant risk of them developing high-risk cutaneous squamous cell cancers. And of all these listed, the most important one is immunosuppression and organ transplantation. These patients, by virtue of being on immunosuppressants, are immunosuppressed, and therefore they have a much higher likelihood of, one, developing squamous cell cancers, but secondly, developing very high-risk squamous cell cancers. And the photograph on the right of the slideshow is a patient who has had an organ transplant. Unfortunately, he's passed away now, but he was a frequent attendee with multiple large and aggressive squamous cell cancers. Literally every 1 to 2 months, he would grow one of these lesions, as you can see on his upper forehead, will grow very quickly. And there are also some genetic syndromes that are pretty unusual, pretty rare, but the real key one is immunosuppression. So that was the history. In terms of when we come to examine these patients, there are sites, particularly in the head and neck. 75% of cutaneous squamous cell cancers occur in the head and neck region, and this is the site of many of the high-risk cases. If we consider the mask area shown in that diagram on the right side, so really the central face, and in addition to those, the ear, pinna, the pink part of the lip, so the vermilion lip, temple, and then also areas of skin that are not typically exposed to sun. So, the soles of the feet, palms of your hands, genitalia. Patients developing skin cancers here, that's one that's really unusual, and there can often be high risk. In addition to the anatomical site, we're interested in identifying if the lesion is large. So generally speaking, anything greater than 2 centimeters, you need to consider that may be a high risk. It's quite cutaneous squamous cell cancer. I mentioned high risk locations in the face region. Oftentimes, if they reach 6 millimeters to 10 millimeters, so less than 2 centimeters, they may be high-risk cases. So what I'm getting at here is that these cases, these patients have histological features when you do a biopsy that demonstrates high risk or a tendency for high risk. High risk, as we mentioned, is local recurrence, metastasis, and ultimately death. So depending on which papers you read, for you to think about depth of invasion, as we would do for melanoma, there's Breslow and Clark levels. Some papers talk about 2 millimeters, others 6 millimeters. I think in the face, we generally use 2 millimeters. Other body sites, 6 millimeters is considered the threshold. But for either site, Clark level 4 or greater is considered high risk. In addition to depth of invasion, we're interested in evidence that the cancer has invaded the the nerve sheath. So perineural invasion, or PNI. This is an extreme red flag. If you see this on a pathology report, you really need to be considering doing something different than a simple excision. When we talk about nerves, we're talking about relatively large nerves, which is defined as a nerve greater than 0.1 millimeters. That is considered a large nerve. And any nerve involvement deep, so in the subcutis or deeper, is also considered high risk regardless of size. Additional pathology, so desmoplastic or an infiltrative growth pattern. So this means that when the pathologist looks at the specimen, the biopsy specimen, he or she is assessing the tumor margin. Is it nice and smooth and uniform, or does it have sort of finger-like tentacles? Is it infiltrating the strands of cells? When they see that, we know that there's a much higher recurrence rate, either locally, but also because of the associated recurrence locally, there's increased risk of metastasis. And then lastly, differentiation. So you may see on your pathology reports, most of the biopsies you do will be described as well or moderately differentiated. Those are sort of your barn door normal, lower risk cutaneous SCC, but we're really interested in the poorly differentiated or the de-differentiated or undifferentiated squamous cell cancers. They have high risk of recurrence and metastasis. And all these features, pathological features, are now included in our staging systems. There's more than one staging system, but if you have one or more of these features, it upstages the patient, meaning that the chance of recurrence or metastasis is greater. So, as I mentioned already, we're concerned with these cases because there is an increase of adverse outcomes, both local recurrence at the primary site, metastasis either in a nerve or the lymph nodes, and ultimately death from distant metastasis. And this could be typically to the lung or to the brain. And so if we start looking at the the actual percentages, the numbers. So local recurrence in a patient considered, a low risk bog standard cutaneous SCC is considerably lower than 10%. Depending on which studies you see, it's even less than 5%. In high risk cancers, local recurrence is significantly greater, 20, 30, 40%. Similarly, with nodal metastasis, there's a real difference in the number of cases that will metastasize to lymph nodes when comparing low versus high risk cancers. And similarly with nerve metastasis, and because of the above, the risk of death is greater with high risk cutaneous squamous cell cancers. So the issue here is that it can be very difficult to recognize clinically a high-risk cancer from a low-risk cancer. Oftentimes, if we have two patients, one has got a low risk, one's got a high risk cutaneous squamous cell cancer, they may look similar in size and shape and color. One of the issues, as I mentioned, is this infiltrative border. We may not be able to clinically see the edge of the high-risk skin cancer, which may extend considerably further than the clinically evident margin of the lesion. Additionally, you can't see perineural invasion. You may detect symptoms related to it, but you can't see it clinically. Here's a case, just coincidentally, I did today. This is a photograph of the lower eyelid. That pigmented area isn't a pigmented lesion, it's just the skin marking. This is what we ended up doing. So we did margin control surgery, and he had 5 excisions. We've got it clear, but it's going into the conjunctiva, the mucosa, and this is because of the infiltrative nature of his skin cancer. So how do we treat these patients? Well, the standard treatment is, as you know, wide local excision. We're aiming for, broadly speaking, a 5mm margin for our cases. The majority of cases which are considered low risk, higher risk patients, we're, if possible, wanting to achieve greater margins. The limitation of standard pathology assessment is this concept of bread loafing, which I've got a diagram here. Here it goes. So here, if you imagine this is your excision, so the black blob is the skin cancer. The white area around that black blob is the tissue, the excision, and you can see in the lower part of the diagram 2 red areas where tumor has been left behind. So we've transected tumor. Now, the standard way of doing histology in skin cancers worldwide is basically taking sections, or if you like, a slice of bread out of the loaf, and then examining those 2 or 3 slices and assessing whether we can see any cancer at the edge. And you can see, in this case, 3 slices of the bread were removed. There's no cancer evident at the margin of slice 1, nothing in slice 2, and nothing in slice 3. So that patient would, in terms of margin assessment, would be reported as margins clear or margins negative. However, if we go back to the actual tumor, we can see that tumor's been left behind. And this is why we have up to 10% local recurrence rate, even if pathology has reported the specimen is negative, margins are negative. And that's because there's been unidentified residual tumor left in the patient. Now, this isn't a criticism of the pathologist. This is just the standard way of doing it. You know how many thousands of cases they have to do every month. They just can't do any more sectioning or any more assessment of the margin than is shown here. And what I'm showing you here is actually basically 1%. Actually, it's less than 1% of the true margin of that cancer. And it's used as a surrogate for what's happening in the rest of your excision. So that's one of the sort of downfalls of the standard pathology assessment of these cases, and why we often trip up when we think we've cleared the tumor. So how do we get around that? Well, if we're dealing with a high-risk cutaneous SCC, then we need to think about doing something different, either taking greater margins, but understanding that even with larger margins, we may still miss a positive margin based on the standard pathology assessment, or we can do something called a peripheral and deep margin assessment. So that means that's otherwise known as Mohs surgery, where the complete margin is assessed, both peripherally and deep. And in those circumstances, the cure rate is significantly greater. I've written here 97%. Again, it depends on which studies you read, but essentially you should be aiming for 99% and higher cure rate. This is important not only for high-risk skin cancers, but also for areas that are considered either aesthetically or functionally sensitive near the eye, eyelids, lip, nose, and some other areas. And the difference here is as shown here. So here is your patient with a cutaneous carcinoma on the cheek. There's the excision. You can see once the tissue has been removed, this cancer has been left behind. That specimen is then converted into slides. And unlike the bread loafing, the entire margin is assessed. And then we can identify that we left tumor behind. So we go back and we take more. On the second go, we've removed one of the areas of residual cancer, but we've left some behind in the second area, and that's been identified and excised. Here's an example. Patient comes in, scalp, difficult to see and assess, one because of the hair, but also clinically it's quite difficult to assess. This is roughly speaking what I thought the margin of the cancer was. So we started, and several hours later, this is what we end up with. So this is highly unusual, but it is what can happen with high-risk cutaneous cancers. So that's what we started with, what we thought we were starting with, and that's what we ended up with. She had a large scalp rotation flap of hair-bearing skin back into the skin defect, so she hasn't got any baldness or any significant issues with her scalp, hair-bearing scalp. So we need to do everything that we can to ensure that we have the primary site treated adequately in high-risk SCC. But what do we do if we have a patient with an enlarged lymph node? Now, here is a patient who has all the hallmarks of a high-risk patient. He's got widespread actinic change of the skin of his face and neck. He's got what looks like a skin graft in the temple region, and he comes along with this large lump just under his ear. Looks like an infected boil. That's in fact metastatic squamous cell cancer in a lymph node, in a parotid lymph node. So that patient needs a biopsy, needle biopsy, ultrasound needle biopsy. It confirms that it is metastatic squamous cell cancer. He then has total body imaging, PET scans. Thankfully, it doesn't show any evidence of disease elsewhere. So the good news for this chap is that he can be cured with extremely high cure rate, 85% or greater. He needs a parotidectomy and a neck dissection and radiotherapy. And we do this frequently in patients, in older patients like this and younger patients, and they tolerate the surgery and treatment, the radiation therapy well, and he has a good outcome. That's what we end up doing. We do a sort of pretty extensive dissection. You might be able to see the facial nerve within the parotid gland here and some large vessels in his neck. So after the surgery, his face is moving back to normal, and he can carry on life as before. So for you in general practice, what should you be thinking about to try and not trip over these patients? So hopefully I've shown you some of the features that will be a red flag for you, and I think we're going to make the presentation available for you, so you can refer to that again if you need to. So remember, we need to consider clinical risk factors both in the history, in the examination. We need to do a biopsy, and we need to really review the report. So we're not just interested in, is this a cancer, is it an SCC, but we need to understand and recognize, is the pathologist telling us that there are high-risk features in this specimen? And if there are no high-risk features and it's a standard cutaneous squamous cell cancer, then by all means go ahead and do a standard excision in primary care. If it's a high-risk lesion, then need to consider ideally referring to a specialist or someone who's got a lot of experience treating these patients. And what can we do to reduce patients' risk, both low and high risk patients? We all know now about sun and UV avoidance, protection, sun precautions, wearing hat, clothing, staying out of the sun in peak UV times of the day and of the year, applying sunscreen frequently, particularly if exposed to water. Secondly, field treatment. So patients with actinic keratoses, even superficial squamous cell cancer, need to really treat them fairly aggressively with 5-FU Efidex. PDT is also a good treatment option. And these, the idea here is it's almost prophylaxis. You want to try and reduce the likelihood of these actinic keratoses progressing into skin cancer. And then lastly, there's what's considered chemoprophylaxis, so vitamin B3, nicotinamide. There's good evidence now, phase 3 evidence, that taking vitamin B3 in this dose here, detailed here, reduces the risk of developing cutaneous squamous cell cancer and BCC by about 25%. So that's really significant, and that's probably the only thing that our patients can do to reverse some of the changes, other than using more aggressive treatments like Efidex. It's relatively cheap. Most patients seem to tolerate it pretty well, so that's definitely something to think about. And I certainly advise all my patients to use that. I won't talk too much. Actually, I won't talk at all about acitretin. That's really for specialist use only. Thank you.
Thank you. That was a really excellent and clear overview. So we'll go to a couple of questions now.
Sure.
And when we're doing a biopsy, what sort of report should we request from the pathologist if we're suspecting a high-risk cSCC?
Yeah, good question. So I think what's probably important is to alert the pathologist that you're worried it's a high-risk patient. And maybe even just record some of the details, immunosuppressed, or is there a recurrent lesion, or any of the features that I've mentioned above, and that will alert the pathologist to think about your concern, and then hopefully address some of the specific factors that I've mentioned in the presentation, particularly some of the histological features. But the key thing is that we're all busy, and we're all try and get through as much work as possible. The most important thing when you get that biopsy report is to read it thoroughly, because the evidence will be there, and you can only act on what's described.
In terms of biopsy, do you have any recommendations in terms of techniques that we should or could be doing in a primary care setting? Just often quite restricted in terms of time and resources. Yeah.
Definitely. So look, I was doing skin today in skin clinic, and I did a bunch of biopsies, and I will either use a curette, ring curette. And so the advantage of a ring curette is that you only need local anesthetic and the curette, and you're basically done. In terms of bleeding, we use topical aluminum chloride applied to the lesions, so we don't need to use diathermy, and then we put a simple dressing on it. So I really favor that, particularly if it's not an aesthetically high risk area like the nose, front of house. It's really quick. Patients then don't have a stitch in it. They don't need to come back, and we confirm them with the results. So everyone's happy. For those that are not suitable for a ring curette, I would then do an incision biopsy with either a 2 or a 3 millimeter punch forceps, punch biopsy knife. And then in those cases, I generally would put a suture in, a 5/0 nylon or something like that, and then a dressing. And then, the downside of that is that they need to come back and get the suture removed. It's a little bit more involved. You need a few more instruments. And then the last one, which is quite controversial, is using a shave, what's called a bioblade. Again, I'll use that. Depending on where the lesion is, again, it's relatively quick. You just need local and the blade. And then again, you can use aluminum chloride to hemostase the lesion and put a dressing on it. There's no suture. So again, you phone the patient with the result as you did for the curette.
Could you speak a little more to the 5FU and imiquimod and what kind of regimes you might recommend?
So until, as the audience probably know, for some time, a sort of fairly prolonged treatment was used with Efidex only, used daily or twice daily. Some people recommend taking the weekend off, but having a several week use of that treatment, typically 3 weeks. More recently, probably actually for the last several years, maybe five years or so, there's been a move to having a combined treatment. And the idea there is that it allows the patient to get away with a shorter treatment, but it seems to be just as effective as using Efidex alone. And so in those circumstances, I'll typically ask the patient to use the combined treatment for 4 or 5 days, and then stop, and then ideally wait for 4 weeks really until the inflammatory reaction is settled before we reassess the patient.
And with the combination treatment, do you mean urea or with the imiquimod?
Imiquimod, yeah.
With
Yeah.
Thank
Yeah,
you.
I don't tend to use urea. Urea I know is used a lot by dermatologists. I'm a simple surgeon. I don't really use urea very much.
Thank you. Could you also speak more to PDT, what it is and when it might be used?
Yeah, okay, good. So PDT is photodynamic therapy, and basically it is a treatment that seems to have fallen out of favor of late, and I think for the following reasons. One is that it's not widely available. Secondly, it's not covered by insurance, and thirdly, it creates quite a reaction on patients' face. So the treatment is basically a photosensitizing lotion is placed on the face. The patient is then brought into a room, and a UV light is shone at the area that's been treated, the face or the scalp or whatever it is, for 30 minutes to an hour. And that desensitizes the lotion, which then works on particularly actinic keratoses or squamous cell cancer in situ. It creates a bit of an inflammation reaction, which isn't nice for the patient. And then the patient then has to avoid sunlight. So there's lots of drawbacks of that treatment, and I think that's probably why it's fallen out of favor. However, it's now there appears to be a resurgence in that treatment because we're now some specialists are now offering that treatment, and instead of placing them in a room and asking them to avoid sunlight, they're doing the treatment in the clinic and then sending them straight out into sunlight and using UV to desensitize the lotion. Anyway, so there seems to be a lot of data coming out on that recently, and it seems to be showing promise in terms of the efficacy is as good as the sort of standard old school treatment regime.
For low risk SCCs, we've got a couple of questions on them. One is, what would you consider adequate margins for it? And the next one is, what kind of follow-up would you expect? Like, should we be examining the skin every 6 months? Like, what would be?
For cutaneous SCC, a standard, what we consider low risk SCC, I think 5 millimeters. I mean, it's been shown 5 millimeters is adequate margin, and again, the pathologist should be recording margins. I think of late they are now just saying margins are clear rather than recording the actual margin. And again, that's, I think, because of resource constraint. Don't quote me on that, but I think that's probably why that's the case. But anyway, in that case, that patient, there's two issues for that patient. One is that low risk SCC going to recur? And secondly, we know now that if a patient develops one skin cancer, they are at higher risk than someone who hasn't developed a skin cancer of developing more. Okay, so that puts them into, if you like, another high risk group. Not that they've got high risk skin cancer, but they're higher risk of developing more in the future than someone who hasn't had any. So they definitely need follow up. One for the one that you just treated, but also for the possibility of developing more. And I think, generally speaking, most people recommend annual follow up for a skin assessment, with education to the patient that, if they see something that's changing on their skin or enlarging or ulcerating and not healing, then they need to come earlier than that 1 year follow up.
I've had a few more questions come through about the 5-FU imiquimod treatment. We had a few questions wondering if you ever combine the Efudix with calcipotriol or the Divanex.
Divanex, yeah. So, yeah, I wasn't as explicit as I should have been. So, yes. So, just to recap, Efudix alone, 3 weeks, daily or twice daily. With Divanex, there's now the advantage that we can shorten that down to about 4 days or 5 days. And they do still get a brisk reaction, but it's over and done with in a relatively short time.
And you mentioned the shave biopsy is quite controversial. Could you speak a little bit more to that?
Yeah. So I do a workshop every year at Goodfellow, and this is one of the things that generates so much discussion. And I've got a video that shows how to do a shave excision, a shave biopsy, and everyone's really impressed how quick it is and easy it is. But people have this fear of doing this because I think there's during our training, we've been advised against doing it. And actually, there's lots of stuff that I've been advised against doing, and I don't really follow that advice, and seem to get good results. So I'm not really sure what it's based on. But I think the primary concern with shave probably relates to pigmented lesions, which I use it for as well. And people are worried that they may leave tumor behind, or if they leave tumor behind, particularly in a pigmented lesion, it may then be difficult for the pathologist to establish the thickness of that cancer or melanoma, and then that might have an impact on how the patient's treated. So we'll put pigmented lesions to the side because we're talking about cutaneous squamous cell cancer. So it really is irrelevant in cutaneous squamous cell cancer whether you transect it or not. Remember, when you're doing a curette or a punch biopsy, you're basically incising it and transecting it either radially or at the deep margin. So a shave essentially achieves the same result.
Are there any immunosuppressants in particular that are higher risk than others, like the biologics or the methotrexate?
Yeah, methotrexate and that sort of family of immunosuppressants are definitely higher risk than, for example, steroid, prednisone or something like that. So, I had a patient with Crohn's disease who had developed, a young patient, only 20, she was 20 something, and, very unusual. She had a, albeit low risk cutaneous cancer, but, a young patient, and she was had been on immunosuppressant for Crohn's disease for many years. So, methotrexate. Yeah.
Got a GP who doesn't have access to ENT or plastic surgery in their region, and they're wondering if it's ever appropriate for primary care to initiate acitretin.
Oh, for an immunosuppressed or i.e. organ transplant patient, short answer, no. Unless you've got experience using it, which I'll be surprised if primary care would. Personally, I don't have any experience using it. I don't use that treatment at all. So I'd be really wary of managing your patients with that. Yeah.
Thank you.
And many, if not all, organ transplant patients do have access to DHB skin cancer clinics because of their recognition that they are high risk.
Any thoughts on liquid nitrogen, particularly on AKs?
Liquid nitrogen, absolutely fine on actinic keratosis. I'm always a little bit wary of using cryotherapy on invasive skin cancers, cutaneous cancers, squamous cell cancer. And the reason why is that whilst you may have a reasonable treatment effect from cryotherapy, oftentimes when it will leave a scar, and you may not identify the recurrence until that skin cancer has recurred beyond the scar. So if, for example, you've got a reasonable size cutaneous squamous cell cancer and you're treating it with cryotherapy and you leave let's say a 1 centimeter white halo scar there, you may not see a recurrence until it's grown beyond that 1 centimeter scar, by which time you see it, it may be 2 centimeters. And now we're into that higher risk group. So I'm always a little bit wary of using it for invasive disease, but keratosis, yeah, fine.
Question around referrals. So how are they graded in public, and is there anything that is helpful for GPs to put on there or include in there?
So probably the most helpful thing is having biopsy and a pathology report, because one, that establishes, is it a cancer, yes or no? And two, is it low risk or high risk? And that's probably the number one piece of advice. Public is definitely really struggling to manage this tsunami of skin cancer cases. And this is kind of one of the reasons I do these educational events for GPs, because we need to train up and encourage primary care as much as possible to help with the tsunami.
In terms of prevention, we've had a query around if topical vitamin B is of any use and if the nicotinamide is of use for those who are low risk, so those not immunosuppressed or organ transplant patients.
Yes, yes. So the second part of the question is yes, definitely. So I pretty much, or everyone who comes through the door, I recommend they consider using nicotinamide. The study in the New England Journal of Medicine was done in patients with biopsy-proven actinic keratoses and or cutaneous carcinoma, non-melanoma carcinoma. A wide variety of age groups. So they didn't actually assess patients without biopsy evidence, AK. My feeling on it is that, look, nicotinamide is a bit vitamin. It's a well-tolerated vitamin, doesn't appear to have significant side effects. Occasionally, patients describe some gastric bloatedness or some GI upset, but it's a minority. But the upside appears to be significant, particularly for population of New Zealand or Australia. So yeah, I recommend it in all my patients. What was the other part of the question? The first part?
Someone had asked about topical B vitamins.
Yeah, good question. So I do know that, by the way, nicotinamide, orally or topical, is also good for skin rejuvenation, and it's certainly used in a lot of cosmeceuticals, skin creams and all the rest of it, because it does appear to have a skin rejuvenation quality to it. I don't know if it has any effect on reducing the occurrence of cutaneous carcinoma. It could do. I'm not aware of any clinical trials or evidence.
Is it something patients just buy over the counter, or are we able to prescribe it?
Bought over the counter. So Blackmores supply it. Until recently, it was actually quite difficult to get hold of in New Zealand. You'd have to go to the Blackmores Australia site and then have it shipped in. But now it's available in Chemist Warehouse and quite a lot of pharmacies now.
Someone is wondering where you source your hemostatic agent, your albumin core from.
Yeah, always get asked that question. And there's a supplier called Optimus,
Mm.
Optimus.
Yes, someone asked if there's any symptoms we should watch out for example, like perineural, that might be indicating perineural invasion or anything like that.
Any?
Perineural invasion or any other symptoms that we should look out for,
Yeah.
apart from the,
Yeah.
the obvious ulceration? And
So, so definitely. So, perineural invasion seems to affect facial or head and neck cutaneous carcinoma more than other sites for a few reasons. One is, as we said, 75% or more of these carcinoma affect the head and neck region. Secondly, the head and neck region is got a dense network of both motor and sensory nerves. The main ones that we're interested in the face and head and neck is the facial nerve and the trigeminal nerve. So if a patient, similar to, you may recall me showing you a photograph of an elderly patient with a skin graft on the temple and a lump in the parotid region. If that patient, minus the parotid lump, comes to you with a facial nerve palsy, so he's got actinic change, evidence of skin cancer surgery in the past, he's got facial nerve palsy, he's got metastatic perineural invasion until proven otherwise. Okay, so facial weakness. Don't assume it's a Bell's palsy until you've ruled out PNI. Okay, and by the way, you probably wouldn't be able to rule it out yourself. You need to refer in because that's quite tricky to establish. You need scans and biopsy of the nerve and whatnot. And then the other one is paresthesia, either numbness or pain in the face. So trigeminal nerve, we've got branch one affects broadly speaking, the forehead. Branch two is the cheek, and then the lower jaw area is V3. And don't assume that they're numb because you've done recent surgery on them. It's a very typical story. You cut out the skin cancer, and then they come back a few weeks later and saying, "Oh, I'm numb here," which they always are. But remember the paresthesia post surgery usually reverses after a few months. If it doesn't reverse, then we've got to start thinking about perineal invasion. And then just remember, it's stark. It's almost like those anatomical drawings. You can just touch the face, and it's the watershed of the V1, V2, V3 is very clear. Okay, typically only one of those branches is affected, unless it's gone all the way back to the ganglion, which is in the intracranially. Then the whole face is numb.
Are any patients receiving or getting good results from immunotherapy?
Yeah, really good question. So I do low risk, high risk cancers, and then I also deal with those are my patients that I showed you. Patients with metastatic disease. 10 years or so ago, the patients in whom had disease metastasizing to the lung or other distant sites were palliative. We couldn't cure them, and they would die. Now, I can't remember the last time a patient with metastatic lung or brain cutaneous sCC has died because of immunotherapy. Yeah. So immunotherapy has been a real game changer for those, advanced, previously considered terminal cases. The oncologists now can not only stabilize, but in some cases show regression of the tumor in the lung or wherever, and disappear on scans. It's amazing.
Wow. When we get the biopsy or the pathology back, are there like certain margins that we need to aim for to make sure that it's clear? Apologies, you might have gone over this, but to make sure it's clear.
Yeah, so ideally we want a margin of 5 millimeters or more. If it's a low risk cancer, I'll tolerate 4 millimeters, even 3 millimeters, as long as I know that patient's going to come back for follow up, and and they're reasonably sensible, and would come back voluntarily if they noticed symptoms or concerns about recurrence. Otherwise, definitely 5 millimeters or more. But that's for the low risk patient. For a patient that's got high risk, so perineal invasion or some of those other features, then I would really then consider referring that patient for an opinion. If you've got access locally, if you haven't, like one of our audience today, then you may need to consider doing a wider excision if you can. Oftentimes, particularly if it's on the face or somewhere that's functionally or aesthetically sensitive, it may be difficult.
On the pathology report, apart from looking for those margins, is there anything else that would flag this as suspicious, or is it often quite obvious they'll say this is a high risk ECC, or is there anything else we should look for?
Yeah, so they'll comment on those features that I mentioned in the presentation. So perineural invasion, they'll record any of the high risk features. If you see any of those high risk features, that patient's high risk. Okay. If they report it as, for example, a moderately differentiated squamous cell cancer of the ear or the arm or whatever, and they don't mention anything to do with high risk, then that's considered low risk. Yeah.
Great, thank you. I think we'll finish up with another FedEx question, if that's all right. And it's just the time frame between applying the FedEx either by itself or combination, and when people can start putting sunscreen on again.
So I tend to avoid recommending FedEx in the sunny, summery time of the year because for a few reasons. One is socially it's not great. You know, people are out and about during the summer, and having a red, crusty face isn't a nice thing to be walking around on the beach with. So I tend to recommend using it in the winter months, sort of April onwards, April to about November, and therefore they can hibernate in the house, and putting sunscreen then isn't really an issue. But essentially, if they did want to go out in the sun or whatever it is, essentially they really need to wait until those crusty, inflammatory lesions have settled, and they can tolerate putting the sunscreen on. And that's typically about 3 or 4 weeks after they've completed the treatment. Yeah.
Okay, thank you for that. All right, we'll wrap it up there. So thank you again to Rajan for sharing your time and expertise this evening. Much appreciated. And thank you to everyone for joining us tonight, and have a lovely rest of your night, everyone. Thank you.